Hello, everyone, and welcome to the first Toronto General and Western Hospital Foundation COVID-19 virtual Q&A for 2021. We hope you're staying safe and taking care of each other during the pandemic. I'm Christian Cote, host of the UHN podcast Behind the Breakthrough. We're glad you could join us and grateful to you, our family of supporters who've been so generous throughout this challenging time. So a big thank you on behalf of the foundation and all of UHN. This episode, we're talking all about the vaccine and the province's latest strategy to get control of the COVID-19 virus. As always, we'll be taking your questions at the end of the show or towards the back half of the show. We're very pleased to have with us today as guests, first of all, Dr. Brad Wouters, UHN's Executive Vice President of Science and Research. Welcome, Dr. Wouters.
Yeah, thanks, Christian. Happy to be here.
And we also have with us Dr. Isaac Bogosh, a UHN staff physician in the divisions of internal medicine and infectious diseases, and a member of Ontario's COVID-19 vaccine distribution task force. Welcome, Dr. Bogosh.
Thanks for having me here.
Before we get into the vaccine, Dr. Bogosh, I want to start with you. Let's talk about virus spread in Ontario. We're several days into the latest new lockdown. Hospital ICU capacity, it continues to shrink. We're already bumping surgeries. And the weekly case count is, around 7 times higher than the first wave. How did we get here?
Well, that's a good one. Obviously, we know what happened in the first wave. I think we weren't clearly as prepared as we would have liked to be for the first wave. There were certainly hiccups with diagnostic testing. There was, we just didn't know a lot about the virus. And quite frankly, we could have done more to prepare ourselves during the first wave. But there should have been lessons learned. Summer came, cases went down, people were outside, things were going well, but there were many, many, many people saying there's going to be a second wave. This is going to get rough as people move into indoor settings for work, school, cold, and there's going to be a lot of factors driving people indoors. We're going to see a rise in cases. It's tough, but quite frankly, we just weren't as prepared collectively as we should have been. And I don't think you can point fingers to one individual person. There's certainly federal issues, provincial issues, city issues, individual issues, institutional issues. There's a lot of different issues, and there's a lot of room for improvement. Here we are. Obviously, we're neck deep in the second wave. It's the dark, ugly days of January. However, I'll stop droning on and on in a second. But if you look at the cases over the last week or so in Ontario in particular, you're actually seeing a trend where the 7-day average is going down, 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 down. So, obviously it's way too soon to celebrate. We are nowhere near being out of the woods. There's still, hospital capacity issues, ICU capacity issues, long-term care facilities are on fire. Like, we still have a ways to go, but there are very real positive trends headed in the right direction. So we might be on the downswing now.
Okay, so with this new state of emergency, I'm curious, what will you be looking for, say, the next 2 to 4 weeks that will indicate to you it's working?
A couple of things. Number one, from simultaneous interventions. Number one, I want to see a reduction in deaths in long-term care facilities. For example, in Toronto, Windsor, Essex, almost all of Peel, York, many other Ottawa, there's not everywhere, but a lot of the provinces had long-term care facilities with the first dose of vaccine. That represents 70 to 80% of the deaths in the country. I want to see a reduction in deaths in long-term care. That's one metric. The second metric is, of course, the number of cases per day. It's not perfect, but if you look at a 7-day average, that's a much better metric because it really accounts for fluctuations in tests. So I want to see that sustained reduction in the 7-day average. The third thing, and also very importantly, is a reduction in hospital capacity or hospital stays and ICU stays with COVID-19. I'll be looking at those metrics very closely over the next few weeks for sure.
All right, so let's bring in Dr. Wouters. Given the dismal modeling that we're seeing for the next several weeks, the race is obviously on to get the vaccine into people's arms. Talk to us about UHN's role, which it's been quite pivotal, since late December in terms of delivering the COVID-19 vaccine to Ontarians.
Yeah, well, Christian, certainly one of the bright lights in all of this has been the development of vaccines, effective vaccines, and at a pace that is unlike anything that has ever been done before. So, a year ago, we were just learning of this vaccine. The sequence had just been identified. And within 10 months, we had 2 vaccines that had gone through rigorous phase 3 trials, had been approved, and not only approved, but demonstrated efficacy levels of 90, 95%, much greater, I think, than even the most generous optimists would have hoped for. So this is certainly good news. But they're coming in slowly. And, we would certainly like to have more now, even though they came faster than we probably would have expected them to. And when we got started, there's nonetheless a demand to get those out and to try and use it as one of our approaches to mitigate the consequences of the second wave that we're in now. So UHN has played a role. We were asked to be one of the 2 pilot sites in Ontario when the Pfizer vaccine was first released in mid-December. We got a very small amount of vaccine along with Ottawa at that time to really pilot out the creation of a facility. There's lots of issues with the way that vaccine needs to be stored. It needs to be stored at low temperatures and so on. So it had to go to places that had those facilities, which includes UHN. So our teams, went to work. They set up a new vaccination center, and within a few days, within a week, they were vaccinating 500 people a day at that center. And that model, that playbook that Ottawa and UHN put together was rolled out at another 17 hospital sites. So there are 19 of these across the province now that all can do, that kind of level of vaccine administration on site. And in fact, at the moment, it's overbuilt. There's more capacity to deliver vaccine than vaccine available. And that's really what's rate limiting at the moment. The other, role that UHN has played has been with the Moderna vaccine. It came a little bit later, just at the very end of December. And within a couple of days, UHN, along with a number of other hospitals, had put together mobile teams. And they've been out vaccinating in those mobile teams, bringing the vaccine to long-term care homes and retirement homes that are part of in the high-risk areas. And Isaac mentioned this, but in the GTA region now, all of the long-term care homes are complete. The majority of all the retirement homes are complete too. So this is a little patchy across Ontario, but in some of the regions, most of those homes have been done. And as Isaac said, what we're all looking for now is to see the consequence this has on the group that has borne the worst of this from the pandemic, the deaths of those in long-term care.
You spoke about effectiveness of the vaccines that have been developed. Talk to us also about what we can expect, though, in terms of adverse events. What are you hearing out there in terms of the most common side effects?
Yeah, well, the vaccines, at the moment appear incredibly safe. They're typical kinds of side effects that you experience with vaccines. You can have a sore arm. You may have a bit of flu-like symptoms, a small fever. But in response to the first dose, those have been generally very mild. There are a few cases of more adverse events, and generally those have been in individuals that have more severe allergies in some cases. There's a bit of a waiting period after you get the vaccine. You're watched for 15 minutes, but really the number of those events and the number of people affected by that is very small, and not unlike that seen typically with other vaccine products.
Back to you, Dr. Bogosh. I know this question has been asked of you a few times in the last several weeks to few months, but this is likely the number one question on all Ontarians' mind and all Canadians' mind is, when can us ordinary Joes expect to get the vaccine?
Yeah, it's a great question. And certainly I've been hearing this a fair bit, and rightfully so. I mean, it's important. We know that, as Dr. Wouters just said, this is a pretty safe and effective vaccine, and we can see how this can really, truly transform our country and how we function. And this is one tool that will actually bring us on closer to normalcy, as we remember before COVID-19. A lot of this, unfortunately, is limited by how much vaccine we get into the country, right? We're relying on foreign companies in foreign countries to produce and ship vaccine to us. We don't make any of this locally, and quite frankly, the federal government has made deals with several different vaccine companies long before we had the results of their clinical trials. And here's my value judgment: they bet wisely. They bet very wisely. Like, they picked winners. There's a lot of vaccines in the mix, and they picked some real winners. Because the messaging, if we were talking about vaccines and when vaccines are going to roll out in Canada, and we were talking 2-3 months ago, the answer was first quarter 2021. If I'm speaking to someone in government and they tell me first quarter of 2021, that means March to me. And as Dr. Wouters said, we had needles going into arms December 14th. So yeah, of course, it's not enough. We need more. That's obvious. But these programs started December 14th, and they'll actually have significant impact, given that the highest of high priority are currently being vaccinated. And there are some success stories in the sense that Toronto and other large swaths of the province, long-term care has been vaccinated. The priority in Ontario, if we're talking about Ontario, it really is, it's going to be a little while. And what does that mean? Well, we have stage 1, stage 2, stage 3. All these slides are publicly available on the Ontario vaccine website. But basically, stage 1 is those who live and work in long-term care, frontline healthcare providers, and Indigenous populations. Okay, that's what stage 1 is. The beautiful thing is stage 1 overlaps with stage 2. You don't finish stage 1 and then move to stage 2. There is going to be overlap. When you can overlap is completely dependent on how much vaccine we actually have. And of course, there are plans. There certainly were plans to start the scale up and overlap and get vaccines into the general community outside of those stage 1 groups. But as many people have heard, the manufacturing plant in Belgium, where we get our Pfizer vaccine, is being refurbished. So we are getting reduced shipments of the Pfizer vaccine probably for the next few weeks. It's not entirely clear, but it might be for 3 or 4 weeks. It's not zero, it's just slowed down dramatically. That's a problem, because that means we, A, have to use our resources wisely, and B, have to scale back on the expansion of this program. I know it's a long-winded answer, but it's important that people are aware of this. So basically, most of the resources will be directed to vaccinating long-term care. As we mentioned earlier, that's where the fire is burning hottest, unfortunately. That's where the deaths are. The vast majority of the deaths are. We really need to protect the most vulnerable. So those vaccines are going to be prioritized to long-term care. And they're even going to stretch out the doses in healthcare workers who have already had 1 dose of the vaccine, who are getting ready for their 2nd dose. I think it's just as a little tangent, it's important to know why there's this delay. It's because they're refurbishing the factory, the manufacturing plant in Belgium, where we get the Pfizer vaccine, because the whole point is they're going to produce 2 billion doses of the vaccine in 2021, rather than 1.3 billion doses of the vaccine. So they're doing this so that they can significantly boost capacity for vaccine production. So what does this mean to us in Canada? How does this, for people listening, what does this mean to you? It basically means that this will, in the short term, this will slow things down. This doesn't impact us in the medium term or in the long term. What's likely going to happen is we'll probably have enough vaccine to move and start stage 2. I'm guessing maybe Marchish or Aprilish. I'm just not entirely sure. But in stage 2, you're prioritizing populations, for example, elderly individuals who are outside of long-term care facilities or retirement facilities in the province. You're prioritizing people with chronic medical conditions. You're prioritizing certain communities that are disproportionately impacted by the virus, for example, some of the racialized or low-income neighborhoods. But the other interesting thing too, and I'll stop after this point, is around that time, we're actually expecting a very, very large shipment of vaccine. So this is really a temporary shortage, and we're really expecting very, very large shipments of vaccines in and around the tail end of March into early April. So, the program, as Dr. Wouters was explaining, we have these 19 nodes in the province where vaccines are being distributed from and also being taken to long-term care. that's not going to be the path forward. The path forward is these vaccines will be at primary care clinics, at the pharmacy on the corner, at public health clinics, in mass vaccine distribution centers, in community centers, in mobile trucks to take it out, for example, to underserviced, homeless, or underhoused populations, like bringing the vaccine to the people rather than bringing people to the vaccine. So you can expect that, but I think it's going to be probably late March, early April before the taps really turn on.
That's really helpful, because I know so many people that's their biggest concern is when. And I get in terms of, the supply really is the linchpin here in terms of when we might expect it. I'm curious, you sit on, the panel that helps guide government in terms of the prioritization. Do you have any sense of logistics? Like, are they calling us? Am I calling them? Do you know how that will work, or is that too soon?
Yeah, there's going to be a lot of communication to really explain to people who can get it and when they can get it and how they can get it. And for example, you're seeing a lot of the red tape cut. So it's quietly behind closed doors. Pharmacies are now, doing what's needed to be done to be able to administer these vaccines. Primary care, there's been communications to primary care physicians saying, get ready, this is coming. Here's how you'll prioritize people as per provincial guidelines. So there's a lot of work that's being done. And then, there'll be public messaging saying, the following people can go to the following places to get your vaccines. Here's, if you're in whatever community you live in, there might be a community center that's administering the vaccines, online ways to sign up. There might be mass vaccine sites like we heard of the Toronto Metro Convention Center, for example, distributing vaccines, although that unfortunately had to be scaled back because of the shortages. But, it's going to be local. It'll be a very, very locally administered product, just like you get the flu shot every year. It should be no different than that.
I want to open up this next session to both of you in terms of we'll drill down a little further on the vaccine in terms of after I get the first shot, or if it's the 2-shot Pfizer after the second shot. What's the time frame, guys, for developing immunity?
Well, we have pretty good evidence from the clinical trials on that. And protection starts pretty soon. So even within 10 days of the first dose, you start to see, pretty dramatic protection in the majority of individuals, not in everybody. And what we also know is that when you receive that second dose, the quality of that immunity, the number of antibodies that you have against that increases many, many, many fold. And this will do a couple of things. It may create stronger resistance against future variants as they arise. And it also will be an important part of creating a durable long-term response that keeps you immune for a long period of time. So it doesn't take very long, Christian. And as Dr. Bogoch said, he's going to be looking for seeing a signal in these long-term care communities pretty soon, based on the fact that we started vaccinating there 3 weeks ago.
Is your sense that you have immunity forever, or is this going to be like the flu shot now? We're coming back every year for a booster.
Well, it's a good question. It's something we don't have a lot of data on yet because, the disease has only been around 10 months or so. So, scientists are studying that immune response. People that have gotten infected and developed natural immunity to it, they're being studied. Most of the data that have come out from that are positive news. It looks like a relatively long-lived immunity. There are both B cells and T cells there are memory cells that allow you to respond again, if you're exposed to the virus. And it all looks pretty positive. But I think, what we know from other kinds of viruses like this is that immunity can wear off over time. It's possible you may need a booster shot, in a year or so. Or longer, but that remains to be seen, and it's something that's being actively studied as people recover, and we'll see also as they develop immune responses to the vaccine as well.
And Dr. Bogoch, once you're vaccinated, can you still spread the virus? Or is there still a window that you could be communicating the disease?
Yeah, absolutely. So as Dr. Wouters was saying, the vaccine's really, really good, but it ain't perfect. It ain't perfect, right? And if you look at the clinical trials, some people got the vaccine and still got the infection. It significantly reduced people's risk of getting the infection, but some people still got the infection. The other interesting thing too is what the vaccines appear to do based on the clinical trials is if you're unlucky enough to get the vaccine and then get the infection, it looks like people are at lower risk of having a more severe illness. So it might mitigate the severity of your infection. I think that's also a key point. The third thing A, reduces your risk of getting the infection, but doesn't eliminate it. B, likely to reduce the severity of the infection if you're unlucky enough to get infected. C, the thing that's being worked out now is, if you are infected, are you less likely to transmit this infection? So perhaps with the lower symptoms, or maybe people are asymptomatic, are you less likely to transmit the infection to others if you're infected but vaccinated? So it's pretty interesting. But I think at the end of the day, like, how do you bring this on back down to planet Earth and operationalize it for a second? You're still going to need to wear a mask, right? After you've been vaccinated, you wear a mask, you practice physical distancing. We're going to be doing that until enough Canadians have had access to the vaccine. It might not be herd immunity at 70% of the population, but we'll probably reach a point where we'll see very low hospitalizations, most people vaccinated, or many people vaccinated, especially the high priority groups. And we're going to start to see a lifting of these public health restrictions. It might come in the late spring or early summer, but at some point we're going to see gatherings allowed in indoor settings and larger gatherings allowed in outdoor settings, and mask mandates eventually lifted, and the border policy softening up as many people in the US and Canada get vaccinated. So a lot of that's probably going to lift in the middle part of the year, I imagine, as more and more get vaccinated.
And we're all looking forward to that.
Yeah.
Dr. Wouters, what's fascinating in all this is the backstory of the vaccine and how it was developed. I keep reading about the miracle of mRNA, messenger RNA, where essentially what the vaccine is doing is triggering our immune system, is my understanding anyway, to learn to recognize the spike protein in the COVID virus and then develop the necessary antibodies to fight it. But mRNA didn't just happen out of thin air 10 months ago. Can you give us just a brief sort of history and maybe biology of what's behind this method of vaccination?
Yeah, sure. So these are what we call genetically encoded vaccines, and vaccines, all generally work the same way. They introduce a component of the virus that the body will recognize and develop an immune response to. And the earliest vaccines used actually inactivated virus or less virulent forms of the virus, and inoculated people with those, and you would develop an immunity to it. What we can do now is that rather than using the virus itself, is that we look at the genetic code of the virus and develop a genetically encoded vaccine. So this is, in this case, we're introducing mRNA that infects cells in your body, which will then produce that spike protein. And so it gets produced, it gets presented to the immune system, and your body can develop a response against that. RNA vaccines are brand new. These are the first 2 RNA vaccines that have ever been developed and approved in this time frame, but they are built on a long history of research in using RNA as a tool to deliver proteins for a variety of reasons. And in fact, the research here started in cancer research. They were trying to deliver proteins, genes to correct defects in patients with cancer. What they discovered is that the RNA itself was very immunogenic. It activated the immune system itself, just like an RNA virus would. And so the work that went on was actually to try and tune down that immune response. But in this case, some of that residual immunity that probably RNA creates, it may be actually helping in these circumstances. But the beauty of it is that this is a programmable virus. This was developed within a few weeks of the virus being identified and sequenced. And so, scientists can use that information, use sequence of the virus of interest, and can rapidly develop, an approach to developing these vaccines. And they potentially are reprogrammable. There's lots of concern now about variants or even immune, escape variants. It's possible to go back potentially and, tweak that RNA, express a little bit different version of that spike protein, and now develop a new immune response to it. And that can be a pretty rapid process. So it's quite amazing to see these come out, and you can bet that there are going to be lots more.
Well, and so you mentioned the variant. Sorry, did you want to hop in there?
No.
Okay. But I want to come back to you, Dr. Bogosh, because the impetus for getting the vaccine out to people as quickly as possible is perhaps heightened because of this variant that's emerged from the UK, South Africa, et cetera. Talk to us about what, and this is modeling, I understand you helped initiate or create. How bad could it get when you factor in this variant?
Yeah, I mean, we have to be very careful here. We certainly see some of these variants, for example, that variant in the UK, gradually take over and become the more predominant variant in an area. And it certainly is. It does appear to be more transmissible compared to, I'm just going to call it normal COVID-19, although none of this is normal, but just for lack of a better word. So it appears to be more transmissible. We've got to be careful. We've got to be very careful. For example, in Ontario, they've isolated, I believe it's now 15 cases of this the variant described in the UK. And of course, you've described a couple of other variants that we've seen in Canada as well. We've got to be very, very mindful of this. And what sort of raised the red flag is, of those, for example, 15 cases in Ontario, 3 did not have any direct link to travel, which means they're likely community transmitted. Someone gave it to someone who gave it to someone. And that's a problem, because we know that these variants can take off. What's interesting, though, is it's no secret. Like, it's not like they're impervious to masks, physical distancing, good ventilation, and hand hygiene. That works. That will work, and that will continue to work. So we know how this infection is transmitted. We know where it's transmitted. We know who gets it and how they get it and what the risk factors are for getting it. We know how to prevent it. It's not that we have to do anything new. It just means we really have to double down on our efforts to create safer spaces for people, to prevent transmission in the community. And of course, when the time comes, to roll up our sleeves and get the vaccine, because that will make a huge difference. Yeah, they're here, and we've got to be very careful about these and watch these closely. The modeling basically demonstrated that as bad, the summary is, as bad as things are, it could be worse if these variants take over. But you know what? There is I don't mean to be an eternal optimist. I like to think, look at the data and make a conclusion. And sometimes we look at the data, the conclusions stink. And sometimes you look at the data and the conclusion's okay. This variant, for example, is all over the UK. But if you look at the case numbers in the UK, they went like this: shot right up, adherence to control measures, shooting right down. Okay, if you look at the epidemiologic curves in the UK, they are getting things under control. They're not out of the woods. There's a lot of work ahead of them, but they can get this under control. Same thing in Denmark. This variant is starting to take over in parts of Denmark. Cases shot right up, massive control efforts initiated and adhered to. Cases are coming back down. So it's not impossible. You can do it, but of course, it takes buy-in. It takes good leadership at the government levels, good leadership at the public health levels, both federal, provincial, and municipal. And of course, it takes community buy-in as well. So there's a lot that needs to be done, but we can do it.
And Dr. Wouters, do we know how these variants will do against the vaccine, or how the vaccine will do against the variant?
Yeah, well, there's lots of work going on to address that too, Christian. The variant that Dr. Bogosh was talking about, the one that's sort of taken over in the UK, there's no evidence that the immunity that is created by the vaccine or by natural infection is ineffective against that strain. So that's the good news. There are other variants. There's one in South Africa that has developed a kind of a foothold there. There's one in Brazil that contain an additional mutation in that spike protein. That there is some evidence that the quality of the immune response is less effective. It's not completely eliminated, but it's slightly less effective. And so the fact that we see this emerging, and we've seen it emerge multiple times in different places, that's what's got people a little bit worried. And as Dr. Bogosh said, our chief defense is to prevent establishment and spread of both normal COVID and these more worrisome variants. Nothing out there too extreme, and potentially there are virus vaccines that could be retooled against that, but it's a concern, and it's part of why driving down community transmission, driving down numbers has to be the top priority right now.
And Dr. Bogosh, pivoting a bit, I'm curious, you're on the front lines. One thing we keep hearing about is hesitancy, that because this the vaccine was developed so quickly, people are saying, you know what, I'll probably get it, but I want to wait till, you know, this first wave of people are have been vaccinated and how it affects them. What's your response to that?
I mean, when you talk about, it's funny. This is, first of all, people with concerns and hesitation towards vaccine. This is something that has existed long before COVID-19, and it's going to exist long after COVID-19. So many of us in, you know, infectious diseases and mostly like primary care have been dealing with this for forever. You know, it's important to, when people are, it's a heterogeneous group. You know, sometimes we throw around terms like anti-vax. Okay, nothing can be farther from the truth. When you talk to people who are concerned or unwilling or just have questions about the vaccine, that's a very heterogeneous group. Some people, no matter what we say, no matter what we do, no matter what data we show, no matter all the reason, the logic, blah, blah, some people are just not going to take it. Okay, obviously that's a problem, but that's just one group. But there's a lot of people as well that just have some questions, have some concerns, have some hesitations. And regardless of what the reasons are or the underlying driving force, I think there's sort of right approaches and wrong approaches. Wrong approaches are shaming and blaming. It's easy to do. We're used to it as humans. We love shaming and blaming. But quite frankly, that's probably not the most constructive approach. I think it just further alienates people and pushes them to the side, and it's not fair. The real approach is listen to people. You know, address their concerns, show empathy, show compassion, take their questions and concerns seriously. Don't sweep anything under the rug. People have questions. We should be answering their questions. It's a public health initiative. You can't have public health if you don't have public trust in public health. That's how public health works. Listen to people's concerns, address their concerns. Many, many, many people will very likely choose to have the vaccine after they're listened to and after you take it seriously. And quite frankly, sometimes we don't know the answers, and that's okay as long as you're open, honest, and transparent about it. But I think we'll see a lot of buy-in. And in fact, you know, obviously there's very different, you know, subpopulations and subgroups in the country. But by and large, when you look at most polls in the country, the vast majority of people, like between 60 high to 80 mid% of the people are going to take the vaccine when it comes their way. That's fantastic. I mean, I don't think we should take anything for granted. We still need to have very good, I was going to say public relations. That's probably not the right word. Just very good. You know, we just need to keep this dialogue open, right? Continue to listen to people, continue to address concerns, continue to, you know, talk about what the vaccine does and what we're learning about it along the way. And I think that will go a long way in building confidence for people to get the vaccine when it is their turn.
That's terrific advice. And Dr. Wouters, in addition to vaccinating Ontarians, UHN is taking a lead role also when it comes to research. Talk to us about some of the more promising trials, perhaps. I know Dr. Feld has he's publishing his results coming up in a couple of weeks. Talk to us about that.
Yeah, you know, so we, you know, as we all hope for COVID to go away and to become protected from infection, there are lots of people that are still infected every day and need our care. And so, you know, the search for more effective therapies and therapies that will prevent development of more severe disease continue. And UHN has been part of this work since the beginning of COVID. The trial you mentioned is from Dr. Jordan Feld. He works normally he works in studying liver diseases and viruses that cause liver disease, and he studies the immune response and how the immune response contributes to the pathology of those diseases. And so he was kind of prepared, and he turned his attention also to to studying the way the disease develops in individuals with initially mild forms and could develop more severe forms. So he launched a trial. It's studying what are called interferons. These are part of our innate immune response. It's not the immune response that responds with antibodies, but it's the first response to invaders. He developed a trial, and that trial has shown positive results in preventing the development of more severe disease. It's moving on into a phase 3 trial now, and could become part of that armamentarium of developing more effective therapies for the people that still will be infected coming in.
And give us a sense, because I think a lot of people don't understand how, I wanted to touch on research and how it's funded. Sort of last word to you about the importance of donor dollars to helping to leverage and get that kind of research going in the first place.
Yeah, well, COVID was a disease that we didn't know about just over a year ago. It's a brand new disease. We didn't have any COVID researchers at UHN, but we did have, a huge number of scientists in all kinds of fields working in cancer biology, working in cardiovascular disease, working in neuroscience, studying health systems research, all kinds of, parts of the research spectrum that are important in disease. But it's that expertise that, and that investment that allows the scientific community here at UHN and elsewhere around the world to be able to respond to a new disease like this in a rapid period of time. And so, our scientists have contributed to better understanding the fundamental biology of the virus, how it interacts with human proteins. They've been studying the consequences on pathology, on blood clotting, on strokes. They're looking at the long-term effects in some individuals that get infections in the cardiovascular system, even after they recover from COVID. And they've been working, to help guide our government in modeling. Dr. Bogoch himself has been working on many of these provincial agencies trying to advise the government so that we're using science and using, rigorous analysis to make the policy decisions and not just, political decisions. So it's hugely important. And, our community of supporters, which are many, many donors in our community, are a key part of enabling all of that. In fact, when COVID was first declared as a pandemic by the WHO, it was our foundation, the Toronto General and Western Hospital Foundation, that went to their community and brought in the first funding to enable the launch of those kinds of research projects that have now brought in over almost $30 million of new support from government agencies and elsewhere to continue this important research.
That's great. I could keep talking to you guys, but I know there's an unprecedented number of questions from our audience, and I want to get to those.
Can I brag for 1 second?
Go ahead.
I'm pretty sure, I got to look this up. Pardon the brag. I don't mean to brag. I think we had the very first published paper on COVID-19. January 14th, 2020, it came online. And it was, we didn't even know it was a coronavirus. It was called the pneumonia of unknown etiology from Wuhan, China. And we looked how it would spread throughout the world through air travel patterns. And I'm pretty sure that's the first published paper. I'm pretty sure that's it wasn't even COVID-19 then. We didn't even have a name for it. I think it was just found out to be a coronavirus, like right before it went to press. Pretty cool. Anyways,
yeah, it's pretty cool.
Throw that in.
Well, it just shows you how our people, like you were saying, Brad, like we didn't have any COVID expertise a year ago. Now we've got hundreds who are researching and finding new ways to, come up with better treatments. Anyway, I don't want to rattle on. I want to get to our audience questions. If we can throw those up on Slido. And guys, I'll do my best to direct who gets what. From Anonymous, should organ transplant recipients receive one of these mRNA COVID vaccines or wait until the next vaccine for COVID is approved? Thanks. Who wants to take that one?
I will. Yeah, obviously any clinical decision, you've got to have a chat with your healthcare provider, with your transplant physician, with your primary care provider. Having said that, these are not live vaccines. So these should be generally pretty safe. Now, people who are immunocompromised weren't included in the clinical trials. That's why on the guidelines you see it says, pregnant women, people breastfeeding, people with compromised immune systems should not be given the vaccine unless you have a conversation about the pros and cons and what we know and what we don't know. But in general, I'm not going to put words in anyone's mouth, but in general, if you speak with a transplant infectious disease provider or a transplant physician, most will want you to get this vaccine. Most will. But again, have a conversation because individual circumstances may differ, but I have a feeling the vast majority of people will be recommending they get this vaccine.
From Mark S., if one is part of the phase 2, like being a heart patient, How exactly is one identified for that purpose so as to be included in phase 2? I'm just referring, Dr. Bogoch, to when you were talking about phase 1, 2, 3 of the rollout of the vaccine.
Yeah, it's going to be very clearly defined. It's going to be very, very clearly defined. So just, right now there's sort of broad brushstrokes, general plan that's available about what phase 1 is, what phase 2 is, how they overlap, the rough dates, all dependent on external vaccine supply. But when phase 2 is starting to roll out, there will be very, very clear communication both to the providers of the vaccine and to the general public about who truly is included.
From Anonymous, what are your thoughts on the risk of getting vaccinated while breastfeeding? All of the advice says to speak with your doctor. You've just said that. But my doctor is very pro-vaccine and unwilling to entertain a thoughtful discussion about the risks. I'm feeling overwhelmed.
I don't mind taking that. So unfortunately, I'm going to have a very similar opinion as your doctor. There's a lot of people that were advocating. It wasn't advocating that people should get the vaccine. It was advocating that women should have the choice over their bodies to determine if they should get the vaccine or not. That's what we were upset with. We didn't want other people making the choice. We wanted women to have the choice to make that decision. And I think it's really interesting because there actually is growing data now looking at the vaccination in pregnant women and in people who are breastfeeding, because they are being included into cohort studies and clinical trials. And based on what we see so far, it does appear to be safe. But I think this is something that people can check in periodically between, for example, when they're vaccinated, to see if there's any data emerging. But I think the key point is no one should make that decision for you. You can make that decision for yourself and have a discussion with someone knowledgeable on that area to talk about the pros and the cons. No one should push you to have it or push you to not have it. These are, people can make decisions over their own bodies.
Next question. What percentage of Ontario needs to be vaccinated for us to return to normal? What is the expected date that would happen? Pretty hard to pin that down, though, I imagine.
September 23rd. No.
Yeah, it's important to remember, the purpose of vaccination. Part of this is protecting the individual, but the bigger reason is to drive COVID, to such low levels that no one's at risk anymore. And, the returning to normal is going to happen when the risk of community transmission becomes so low that, life can be normal again. And we see parts of the world that have achieved this without the vaccine. They went into really hard lockdowns. They drove COVID to extremely low levels. We've seen what New Zealand has done, what Australia has done in other places. And life is pretty normal there. It's not completely normal. We have to monitor the border. You need to be watching for this. You need to be testing for it. You need testing and tracing and isolation. And we're going to need that for a long time. COVID, there are 750,000 documented new cases every day around the world. There's a lot of virus out there. And to get complete immunity, that'll be achieved in a subset of the population, but we'll have measures in place for a long period of time to be able to track this vaccine to respond to it. But our goal, is to get it really, really low so that your risk is low and life, and the lockdowns and so on, most of that can come back to normal.
Question from Nancy. Do you have any info on what restrictions people will face in Canada and elsewhere if they decline to have the vaccination? Workplace, travel, need to wear a mask till the virus is eradicated?
I love this because I don't have a clue, but there are hints. You can sort of see hints about what the future might look like. And for example, Qantas Airlines was saying in the future they're going to want everyone on board to have evidence of a vaccine. If you send your children to school, you have to have proof of vaccination, for example, to, measles, mumps, rubella, to send your kids to school. We might very well see that. You have the choice to get a vaccine. No one's going to force you to get a vaccine, but you can't participate in X, Y, and Z unless you have evidence of the vaccine. I think we might start seeing things like that pop up, but I'm not entirely clear. And certainly I think certain workplaces might require evidence of it, especially if, for example, you work in an area with a vulnerable population. I mean, you can't bring COVID-19 into those areas. So I would imagine that we're probably going to see some in some policy mostly at schools and businesses, I think. But we'll see how that unfolds. It might be a bit of the Wild West for a bit.
I sort of wonder also about, wearing a mask. We've seen how effective the best evidence of how effective these public health measures are the fact that there's no influenza this year. Nobody's getting the flu.
Right.
And even the common cold is down by about a factor of 3. So this, the public health measures that people are taking to prevent COVID are, having an effect on other communicable diseases. And there are parts of the world, those who travel to Asia and other places where wearing a mask is a much more
commonplace
thing to see. And I suspect that some of this is going to survive, and we're going to see more mask wearing, at least for a period of time.
This is an intriguing question. Should people who have recovered from COVID get the vaccine? I guess they're operating on the premise that once you get COVID, you have the antibodies and you're immune.
You should get the vaccine. You should. Yeah, because we know that people who recover from the infection are still at risk of getting reinfected. Like, there's credible cases of reinfection, and in fact, immunity probably lasts for months, plural, maybe a year. There's a really neat study out of the UK very recently just demonstrating that people that were starting to get reinfected by about 5 months after they've recovered from infection. So I think I think people should still be getting the vaccine after they've recovered from infection.
Next question. For an individual who has experienced anaphylaxis in the past due to food allergies, what are the current recommendations for which vaccine to get or avoid? Do we even have a choice? Let's start with the question first. Who wants to take that one?
I'm happy to. I don't know. Brad, I can't see Brad. I can't see anything on the screen, so you have to point to one of us.
Dr. Go ahead, Isaac.
So I think an allergy to this is rare. Actually, in the United States, they've given 13 million vaccines, but at the time where they gave 1.8 million vaccines, they had about 20 something allergic reactions. About 22, I forget the exact number. It wasn't that many. And we're talking about on the severe end of the spectrum. So most people who have food allergies are going to have no issues with this whatsoever. You can actually go on the Health Canada website. It lists every one of the ingredients in this vaccine, and you'll see. First of all, you'll be impressed that there ain't much in there. It's a little bit of sugar,
isn't it?
And some mRNA, right? That's basically what it is. But there are some components that stick it all together, and some people do have allergies to that, but it's exceedingly rare. Not impossible, exceedingly rare. Go on Health Canada. That's a reputable website. You can see all the ingredients. You can flip it to your allergist or your primary care doc. But most people who have allergies shouldn't have a problem with this.
To this point, though, are we going to have it? We're not going to have a choice of which vaccine manufacturer we can choose, are we?
Not yet. But I mean, really, truly, if the taps truly turn on in April, which they're expected to, and perhaps if we have we approve one of the other vaccines that are coming through the pipeline, like AstraZeneca or Johnson & Johnson, if you can imagine a scenario where you're in the summer and maybe there will be a choice. But currently, it's like they say in kindergarten, you get what you get, you don't get upset. And also, quite frankly, if you're going to choose between, Pfizer or Moderna, who cares? Really, who cares? At the individual level, it's like the exact same thing. They both have the same safety profile, the same efficacy profile. The only difference between them is, totally external to what happens in you. It's how they're shipped and stored. It's not like the safety and the efficacy is almost identical. I wouldn't care. I'll take any of them.
From Ms. Ross, further actually to this point, what are the differences between the two vaccines available now and the Johnson & Johnson or other vaccines being considered by the Canadian Drug Review and Approval Process regulators?
So as you heard, the two vaccines available now are very, very similar to each other. They're both mRNA vaccines. They're delivered in a similar way. They both encode the same spike protein. So they're extremely similar, very similar efficacy, very similar safety profile. So not much to choose between those two. A little bit different on the logistics and how we have to store them just because of how stable they are. But really, that's the only difference. The next two that are really in the pipeline for approval, the Johnson & Johnson and the AstraZeneca, these are DNA vaccines. They're also genetically encoded, but they're using DNA to do that. And they also are encoding the spike protein. And that's probably on the basis of why they show similar levels of effectiveness and a safety profile too. The DNA vaccines use a different kind of a structure to deliver that. They potentially could have a somewhat different safety profile, but everything that's we've seen in the clinical trials and so on suggests that these are very, very safe vaccines and not much to choose from between them.
Interesting. Okay, so next question. What is the consensus now on getting the virus from groceries and packages? I have stopped wiping everything, but I'm wondering if I should start doing it again. Does the health community still believe that the virus can live on surfaces for a few days? Dr. Bogosh?
Pick me.
Yeah, I knew that one.
Yeah, it's like, oh, that's so first wave. No, but
Yes.
but in all fairness, listen, in all seriousness, there's a couple of points here. Our understanding of how this virus is transmitted has certainly evolved quickly and changed with time. And the role of touching an inanimate object and touching your eyes, nose, or mouth to get this virus went from being what we thought was this big and is now this big. It's not zero. You still have to have good hand hygiene. But I think by and large, people shouldn't be too concerned about, putting the mail in the garage for a few days or washing every surface over and over. Like, it's probably not really adding much incremental protection, if any. Wash your hands is very, very reasonable. So
even with the new variant?
Same. I wouldn't change anything. I wouldn't change a thing. Having said that, I think it's extremely important that we recognize that everybody's risk threshold and risk tolerance is different. And if that's what gets you through the day, kudos to you. Again, sort of like what we were talking about before, there's no shaming and no blaming. And some people might feel more comfortable washing down the items just in case. Go for it. It's probably not adding that much incremental protection, but I completely appreciate that. That might be what's getting someone through the day. That's what enables them to go to the grocery store. I'm all for it if that's the case. But in general, most people have moved on from that.
Fair enough. From Katie and Eddie, as parents of two girls, aged 6 and 9, we are anxiously awaiting a vaccine approval for children. When can we expect to receive a vaccine for children aged 18 and under? Thank you.
Yeah, so this will probably be a staged process too. There are trials that are underway with children looking at the safety profile. That'll probably be in 16 to 12 first of all. So your girls 6 and 9, it may be a little bit longer. My guess is that they're going to get protected by driving community transmission down before they are eligible for a vaccine. But that remains to be seen. I don't know, Isaac, if you have any other insight on that.
No, I mean, the clinical trials are now enrolling people age 12, and that data is probably going to be available mid-year. And just like these clinical trials, we had enrolled 18 and up, and we said, okay, we can give them to 16 and up. I wonder if they'll do these clinical trials for 12 and up and say, okay, they're good for 10 and up. I don't know. I don't know I truly don't know what the crystal ball is a little foggy on that one.
Question for you, Dr. Bogosh, to follow off of this, because I think for parents, this is incredibly important. Say the parent's number comes up to be eligible in terms of their risk category. But these kids, because they're under 16, so the parents are going to go get vaccinated, but the kids can't, or can they go and talk to their doctor about the risk factors if their kids under 16 can safely have the vaccine?
Yeah, so it's really interesting because if you actually look at the guidance, the federal guidance document, vaccines should, at some point, like perhaps in the summer, anyone who wants a vaccine can get a vaccine, but that's really 16 and up. But if you look at the federal guidance document, it actually says, for those perhaps with underlying conditions or for, extenuating circumstances, 12 to 15 can be vaccinated. But again, it's sort of like that immunocompromised breastfeeding, pregnant group where, they say there's no data, you have to have a conversation about the pros and the cons, understanding that there's no data, but it shouldn't be withheld if people are making an informed decision for themselves. So that's a very good point.
From Eva, while we wait for an increase in vaccine distribution and administration, why is surveillance testing at workplaces and in-home rapid test kits not being made more readily available. Even if home test kits are not as accurate as the gold standard PCR test, is not good better than nothing at all? Dr.
Can I brag?
Yes, yeah.
I literally have an article in the Globe and Mail today talking about this. Yeah, I agree. That's pardon the brag. Sorry, I don't mean to brag, but like I feel very strongly about this. I agree completely. We have rapid tests available. The federal government and the provincial government took steps to get access to rapid tests. We just haven't deployed them. You will see them deployed more and more, but we probably should have done it earlier. Look at Nova Scotia's done a great job deploying rapid testing. I think other provinces can take a page out of that book and apply it. And you know, of course, there's nuance, right? You have the right test at the right place to address the right issues. We know how to do it. We know how these tests work. We know the characteristics. We know how to deploy them. And I really, I completely agree. We should be pushing for more rapid testing in many of these settings. One other thing, and this is an important point. People mistake rapid tests for diagnostic tests. They're not. There's diagnostic tests, which is a laboratory test to help detect if somebody's sick, and then rapid tests, which we would really use more as a public health intervention, as a screening tool to screen people who are otherwise well, who might not have symptoms yet, or who might have very, very mild symptoms, to rapidly detect them, to say, oh, by the way, you've got an infection. You're really trying to capture contagious people before they spread the infection at a school or a business or, you know, in a congregate setting. So that's really the purpose of them. I completely agree. I think we could be doing a much better job on that front.
Dr. Wouters, this one's for you, I believe. Thank you for taking my question. Why can't we pay for the formula and recreate the vaccine? With all the delayed vaccines, wouldn't it be easier and even more cost efficient in the long run? Ingredients are not from Mars. We just need the proper combination of ingredients.
Yeah, it's about manufacturing. So, you know, absolutely, it would be great if we had manufacturing capacity and we could, you know, open this up in Canada, and we would absolutely do so if that manufacturing capacity was there. There's a lot to that, you know. There's a lot around quality, safety. You know, those plants need to be properly certified and so on. So it's more than just having the ingredients, it's really having that skill around manufacturing. I have to say it's pretty impressive what these companies have done. Moderna is a brand new company. You know, people were worried, did they have it? Do they really have the ability to scale? You know, Dr. Bogosh said Pfizer is going to produce 2 billion vaccines this year in plants around the world. So it would be great to have more of that capacity in Canada. I think it's going to be one of our lessons that, you know, when we look back at this, we would have more opportunity for vaccine if we had more of a presence of these kinds of companies and more of a manufacturing presence in the country. I think we need it. I think lots of other people think we need more of that. And we'll see that going forward. But it's not as straightforward as sort of just, you know, ordering it up, mixing it and saying go.
Is it reasonable to assume that members of the same household would receive the vaccine at the same time? Dr. Bogosh?
Yeah, why not? Why not? I mean, I'm just going to make an imaginary scenario. Let's hypothetically say people are, I don't know, 70 years old, married. Like, why not? You know, when you know, in April, whenever we have access to more vaccines, you can sign up, get your, you know, vaccine at your primary care clinic, the pharmacy. Why not be able to sign up and have two people get it at the same time? I think we're going to see that. Yeah, very reasonable.
This is going to have to be our last question. I want to thank all of you out there. You broke the question barrier today. I think over 500 questions. We really appreciate it. We apologize we couldn't get to all of them today. We're so pleased that you could join us, though. Last question, probably to you, Dr. Bogosh. Could you please explain the meaning of ICU capacity? Are there separate ICU capacities for COVID-19 patients and non-COVID patients like heart attack and stroke?
Okay, great question. In general, ICU is a very special bed because you have specialized people that work in that area, and it's not just doctors, it is a team sport. You have specialized nurses and respiratory therapists and dietitians and physiotherapists and occupational therapists, a true team sport that are all trained in ICU. Plus you have the bed, okay, which means a physical bed, which you can attach, and the equipment that you need. So a ventilator to help people breathe if they really need that additional support. So there are kind of a finite number of beds in the province. We have the ability to have surge capacity. So you've heard we probably can add about a few hundred more beds by canceling this and that and canceling surgeries and retrofitting hospitals based on with existing resources. But it is kind of a finite resource. So and it doesn't matter who's in that bed. You can have a person who has a heart attack, a person with a stroke, a person with COVID-19. But what's really unfortunate is we're watching that finite capacity fill up with patients with COVID-19. So there's fewer beds for people with non-COVID-19 related issues. That's why they're scaling back surgeries, not elective surgeries. There's nothing elective about it. These are scheduled surgeries. Someone's hip surgery, someone's heart surgery, someone's cancer surgery. They're scaling that back temporarily because we have a huge influx of patients with COVID-19 who are using that ICU capacity. What's the solution? Drive community rates down in the community. Okay, good policy, sound policy to drive community rates down. Less cases in the community equals less cases in the hospital, which means less cases in the ICU, which means less death, which means less cases in long-term care facilities, which means less cases in schools. Drive cases down in the community. That should be our front and center effort. You want to get your life back. You want to get the economy back. You want to get schools back. Drive cases down in the community. That's the way to do it. Of course, now you actually have to do it, which is easier said than done. But that's really the point.
That's a perfect note to end this on. I hate to end it. You guys are fantastic to speak to, but we've come to the end of our time today. To all of you out in the audience, thank you for joining us. To Dr. Brad Wouters, Executive Vice President of Science and Research at UHN, and Dr. Isaac Bogosh, a UHN staff physician in the divisions of
infectious diseases
and internal medicine. Hey, I remembered one. Thanks so much for taking time out of your busy day and sharing your insights and expertise. As always, this live stream will be available on the Foundation YouTube page. For anyone interested in donating supplies, first of all, or support items for our frontline workers, you can email covidsupport@uhn.ca. That's covidsupport@uhn.ca, and someone at the Foundation will be glad to help you out. And finally, donor support. It plays a critical role in helping the Team UHN on the front lines as they care for and treat COVID patients. And as you heard from Dr. Wouters a little earlier, donor dollars fuel the research initiatives of hundreds of scientists working to improve and discover new treatments for this deadly virus. So if you have the ability, we ask you to consider making a donation. You go to www.tgwhf, that's tgwhf.ca/help now. Thanks for tuning in. We'll be back next month with another episode. Keep an eye on your email inbox for details. In the meantime, keep practicing physical distancing, wash your hands often, and mask up. Thanks, everyone.